Thank you so much, Francesca, for your introduction. It's a pleasure for me to be here today to discuss this topic. And in particular, we have to keep in mind that during the last decade, there has been an enlargement of HBV biomarkers capable to detect, to reflect more and more accurately HBV replicative activity and also to reflect the extent of intrahepatic HBV reservoir in terms of amount of cccDNA and its transcriptional activity. This enlargement of HBV biomarkers has led to the optimization of classical biomarkers on one hand in terms of improved sensitivity and in the capability to quantify biomarkers for whom only a qualitative detection was available. On the other hand, this enlargement has led to the de novo development of biomarkers. And as you can see in this slide, this is the case of correlated antigen and HBV RNA, even if further additional biomarkers are under development. What are correlated antigen HBV RNA? Correlated antigen is defined as a pangenotypic composite marker. Pangenotypic since its quantification is not affected by the genetic backbone of HBV genotypes. Composite since it quantifies 3 viral proteins, all produced by the same open reading frame of HBV genome. Conversely, HBV RNA measures viral transcripts circulating in the bloodstream, including viral particles containing pregenomic RNA that has not been retrotranscribed. But which is the clinical positioning of these biomarkers? In which clinical setting can they provide an added value compared to the classical ones? In particular, the scientific community is evaluating the role of these novel biomarkers in predicting liver disease progression, including the risk of liver cancer. Let's remember that HBV is endowed by direct pro-oncogenic properties. In particular, we know that the natural history of chronic HBV infection is composed by different phases. However, there's the evidence that more than 50% of people with chronic HBV infection do not fall inside any of these phases, since they display intermediate characteristics, and for this reason, they are defined E-positive or E-negative grid zone patients. Here, we have the diagnostic objective to identify grid zone patients who are at risk of liver disease progression and thus patients who need a more accurate monitoring or in which treatment should be prioritized. At this regard, this study, recently published on Journal of Hepatology Reports, has shown that correlated antigen is an independent factor predictive of liver cancer, and when introduced in a specific clinical score, it can predict liver cancer better than HBV DNA. This result is in line with previous studies led in people receiving NUC treatment, showing that a persistent detection of correlated antigen over time can help identifying people more prone to develop liver cancer despite virological suppression and despite an undetectable HBV DNA. But of course, the role of these biomarkers have been evaluated also in the setting of therapeutic outcome. And we all know that so far the scientific community is evaluating strategies aimed at improving the rate of HBsAg loss. HBsAg loss is so far the surrogate marker for HBV functional cure that, as you can see in the slide, is associated with several advantages, including a reduced risk to develop liver cancer and in people with HIV, the possibility to start a tenofovir taf sparing regimen. Paradoxically, we can increase the rate of HBsAg loss by nuke suspension, by suspending nuke treatment. And the rationale underlying this strategy resides on the fact that after a prolonged virological suppression, nuke suspension determines a reuptake of viral replication. And this reuptake plays a pivotal role since it can, let's say, awaken our immune response against the virus, thus promoting the achievement of HBV functional cure. However, the outcomes associated with nuke suspension can be variable, and so here we have the diagnostic objective to define people who can safely suspend the treatment with no risk of severe clinical events. This study is interesting since it has the advantage to have analyzed liver biopsies at the time of nuke suspension. The authors found that a reduced cccDNA transcriptional activity at the time of nuke suspension correlates with an increased probability to achieve HBsAg loss, suggesting that a limited intrahepatic reservoir is a key factor promoting the achievement of HBV functional cure. But in clinical practice, how can we understand people who have a limited intrahepatic reservoir? Different studies, including this one, have shown that having an HBsAg less than 1,000 international unit per ml at baseline, so a low HBsAg, correlates with an increased probability of HBsAg loss, but has supported in this systematic review and also suggested by the new version of the current guidelines, the diagnostic accuracy of HBsAg can be further improved, further increased by integrating, combining HBsAg with correlated antigen and HBV RNA. And so, potentially, people with a low HBsAg coupled with an undetectable correlated antigen and HBV RNA may be potentially candidate to nuke suspension. But of course, we all know that so far there's a huge effort in identifying novel drugs with novel mechanism of action to achieve HBV functional cure, so to go beyond the classical concept of virological suppression. There is a consensus on the fact that the achievement of HBV functional cure will require a combination treatment based on the use of drugs that can reduce the burden of viral antigens release. And this is critical since an elevated production and release of viral antigens plays a critical role in inducing the exhaustion of the immune system. And these drugs should be combined with immune modulants capable to restore the immune response against the virus. The drug that is in the most advanced phase of clinical trial is bepirovirsen. What is bepirovirsen? Bepirovirsen is an antisense oligonucleotide capable to induce the degradation of all viral transcripts. At the same time, there's the evidence that bepirovirsen is endowed by immune modulant activity, presumably by activating innate immune responses. These are the very well-known data published on New England Journal of Medicine, showing that after 6 months of treatment, 50% of people has achieved an HbSAg less than 10 international unit per ml. That is a very good result. 26% has achieved HbSAg loss maintained in 12% 6 months after suspending treatment. These are the results in people receiving NUC treatment, but very interesting superimposable results are observed also when bepirovirsen is administered as monotherapy without NUC treatment. However, this reduction in the rate of HbSAg loss after suspending treatment is an expected result, since this type of drug does not directly interfere with the cccDNA transcriptional activity, but they act downstream on viral transcripts that have been already produced. An important result is that the highest rate of HbSAg loss is observed in people with a low HbSAg at baseline, again supporting that a limited intrahepatic reservoir can play an important role in promoting or, let's say, accelerating the achievement of HBV functional cure. A combination that is under evaluation and discussion is the one reported in the slide based on the use of elebsiran and tobevibart. Elebsiran is an siRNA. A siRNA can again induce the degradation of all viral transcripts, but by a mechanism that is different from that observed for the antisense oligonucleotide. Conversely, tobevibart is a monoclonal antibody that can prevent HBV entry into the hepatocytes, but at the same time, it can stimulate antibody-dependent immune responses against the virus. These are the data presented at last EASL around 1 month ago. This study shows that after 1 year of treatment, 16% of people has achieved HbSAg loss. This percentage is increased up to 28% when interferon alpha is included. However, the rate of HbSAg loss is reduced to 16% 6 months after suspending treatment. This percentage is slightly higher than that observed with bepirovirsen. However, here we have 3 drugs, and so a triple therapy administered for 1 year. Conversely, with bepirovirsen, just 1 drug administered for 6 months. Again, the highest rate of HbSAg loss is observed when HbSAg levels are low at baseline, and so here we have also the need to optimize strategies for people with higher levels of HbSAg at baseline. We have to understand if just prolonging the duration of treatment will be sufficient to induce in these patients HbSAg loss. Lastly, it's noteworthy to focus the attention on this treatment combination that is based on a new entry inhibitor plus PEG interferon alpha. These are the data presented at last EASL, showing that during treatment, there's a group of people, few people, who clear a cccDNA. So these people achieve cccDNA clearance during treatment by a sensitive assay. However, they remain HBsAg positive. And so here we have to make a consideration. We know that HBV can integrate its DNA into the hepatocyte's genome. We know very well now that this integrated HBV DNA can be an important source for HBsAg production even when cccDNA is silent or completely absent. This means that a patient can achieve functional cure, can silence cccDNA, but we cannot recognize it since he or she remains HBsAg positive due to the production of HBsAg from integrated HBV DNA. So this can challenge the use of HBsAg as the only marker to monitor the achievement of HBV functional cure, and potentially highlights the need to integrate HBsAg with additional biomarkers, including correlated antigen or HBV RNA, to better monitor the kinetics of intrahepatic reservoir during treatment. But what about Delta virus? We have discussed about HBV biomarkers. A different scenario has characterized the Delta virus, in which, as we heard yesterday afternoon, the scientific community has worked to promote the screening in order to fulfill the recommendations of the current guidelines, and has worked to optimize diagnostic assays for HDV, in particular for HDV RNA quantification that we know to be critical for the diagnosis of chronic Delta infection, but of course to monitor response to drugs. And indeed, the introduction of bulevirtide has prompted the development of several assays for HDV RNA quantification, characterized by different diagnostic performances and in particular sensitivity. And regarding sensitivity, I would like to briefly draw your attention on the results of our multi-center study. In particular, we found that by analyzing serial dilution of the WHO reference standards, we found that, as expected, the lower limit of detection varies across the assays. But the lower limit of detection varies also across the different centers that have used the same assay, thus highlighting a not negligible interlaboratory variability and thus the need to harmonize the diagnostic procedure. This result is in line with the analysis of clinical samples, showing that for HDV RNA concentration less than 100 international unit, the rate of HDV RNA detection underwent an important drop, with only few assays capable to detect few copies of viral genome. These results should be taken into account in the light of the fact that the scientific community is evaluating strategies aimed at achieving a finite course of bulevirtide treatment. And so here we need highly sensitive assays that can help identifying patients who can safely suspend with no risk of virological relapse. This concept is reinforced by this study that has been presented at last EASL. This is an interesting study showing that an early achievement of undetectable HDV RNA during bulevirtide treatment and a longer duration of undetectable HDV RNA are the two key factors predictive of the maintenance of HDV RNA 1 year after suspending treatment. This means that these two parameters could potentially help us identify patients that could be more prone to achieve Delta infection cure. But is there a room for novel biomarker in the setting of Delta virus? The scientific community is focusing on the quantification of HBsAg isoforms. We know that so far commercial assays can quantify total HBsAg defined as the sum of all isoforms, but recently novel assays have been developed to discriminate and quantify the different isoforms, and Stefano Danna will present the 8-hour experience in this setting. And so, in conclusion, we can say that we are at the dawn of a new, compelling, challenging, at the same time fascinating new era in which we have to work to identify novel drugs. We have to understand how to combine them. We have to promote screening. We have to harmonize diagnostic procedures and to understand how to include the use of novel biomarkers. And this will be pivotal for the achievement of HDV and HBV cure. And I thank you for your attention.